I want to invite to the stage Ann Rote, President and CEO of Molina Healthcare of Texas, Kevin Denmark, the Vice President and Texas State Director for Beacon Health Options, and Representative John Zerwas, physician and Chair of the Appropriations Committee. Let's give them a round of applause. Why don't you come on over here and grab a microphone. Welcome to the stage.
Yes, sir. Appreciate it.
I will just say that in this time of Me Too and all that, I'm always sensitive about calling legislators, representatives, or physicians, doctors, and then referring to other people by their first name. So I'm going to call you John, if you don't mind. But Kevin, I'm going to ask you first, because you picked the chair closest to me. Why don't you tell us first, at Beacon Health Options, a managed behavioral health care organization, tell us the kind of things you are thinking about on the horizon as you are trying to navigate this time of uncertainty in healthcare. What are the things you're watching as you're trying to lead the organization?
So my responsibilities at Beacon are scoped into Texas, and there's been a lot of conversations about, hey, what's going to happen in 2018? And I kind of disregard that question, and I say, I have no idea, and I'm confident sitting up here because I think that there's a lot of professionals that would say, I have no idea what's going to happen short-term in healthcare. So I would propose that we talk about what's going to happen by 2021 in the state of Texas. And I think particularly here in the state of Texas, you have a convergence of a lot of things that are going to happen in 2021. Every session that I stepped in talked about the 1115 Medicaid waiver. We got $5 billion by 2021 that is going to slowly go away. Half that goes into uncompensated care, half of it goes into the district programs. We have Medicaid managed care, MCOs, being reprocured in 2020. They're going to just be operationalized and probably starting to do real managed care by 2021. And I would say, humbly and frankly, that's a lot of reprocurements for the state to do in very short time. So 2020 operations of our entire Medicaid program being revamped is ambitious at best. So I think we're still going to be doing some of that in 2021. You also have the state demographers saying that 2021's first time the state's going to be a minority majority. So our population is changing as well as growing. Of the top 10 fastest growing cities in the United States, 5 of them are in Texas. So we have a growing population. And then finally, we have the 87th legislative session that's going to start. So we have one before that. But we'll have the 87th that's going to be at the convergence of all this. Plus, possibly, and this is one guy's opinion, there would be a change in the administration leader of the executive branch. If there's not a change in the executive branch, there's certainly going to be different things that fall out of our election cycle in the next 4 years. So I looked at 2021 in particular just because I can humbly say I don't know all the specifics that's going to happen up until then. But we can talk more about that. But I think between now and then, it's just disruption. And that's probably what this conversation's about.
And let me ask you to sort of follow up on that kind of general question about how you navigate this time of uncertainty. Molina's got a big footprint both in Medicaid and on the exchange, and if one is stable one day, the other one isn't, and vice versa on the next day. How do you kind of keep moving forward when things are changing on the policy and in the marketplace so rapidly?
It's a great question, and I think it's something that each of us in this room probably struggle with. I think we have to have a view on many different things at the same time, right? So operational basics, we have to do exactly what we've been contracted to do. So we need to pay claims, we need to answer phones, we need to take care of members, we need to do all the things that we need to do, because as a Texan and a taxpayer, I want to make sure that I'm doing what I should to be a good steward of our resources. So we kind of have making sure we're doing things that we should, and then we need to be flexible and innovative at the same time. And I think the biggest thing for me is collaboration. Nobody can do this by themselves, and the healthcare system has so many different players that are so important, and I think there's a growing recognition that social determinants of health and other players have a big impact on healthcare, and on the spend and then the eventual productivity of the individual in this society. So I think it's important that we're flexible and we collaborate with others. You know, there's not an insurance company in the world that's ever written a prescription or admitted somebody to the hospital. So we need to work with our providers who do those things and help us learn how to do a better job.
So, Mr. Chairman, Representative, Dr. John, how do you, I mean, let me preface by saying thank you for being here, sir. And I think not everybody here tells me everything, of course, but what they tell me about you is they all like you. Most people like you. I haven't heard anyone say anything bad about you. Not yet, anyway. And I think I'm talking to the right people. And I think that they respect your approach on health policy, informed not just from your professional background, but your general demeanor to policy. And so I wonder how you would address a similar question, but tailored to the legislature, which is, how is it being a healthcare professional, but being a senior and respected legislator, trying to talk about health policy in this time where it feels like a lot of the political conversation has kind of gone off the rails in many ways. I think the values and the principles that underpin it are good and high integrity, but it doesn't always seem like we're using the same words or talking with one another as much as we might be talking past one another. How does that feel from where you sit as a physician?
Right. So basically, I think the position that I've been in is day in and day out. I make my living in healthcare, you know, and day in and day out that is made by anesthetizing people in operating rooms, you know, and so it's a very per click basis. That's how we make our money. That's how we pay the bills tomorrow and next week and so forth, you know. But that's also a big driver for where the costs are out there. And so I think just looking at it from somebody who lives in the healthcare world, makes their livelihood out there, and is part of a very large organization that really was generated and is intended to respond to, in fact, the way we currently do business as a very large anesthesia practice, big footprint, and therefore, you know, a voice that comes to Molina and says, hey, I think this is what I'm worth, you know, and let's cut a deal. And so I think we continue to see that, and you spread that out across the entire healthcare sector, and you can see kind of the place that we are. From a policymaker point of view, what I view, and it's very focused on making sure that the Medicaid program and the CHIP program and all the other healthcare programs in the state function in a highly cost-effective way. Because if we don't, it's going to be that 800-pound gorilla that's going to eat the revenue from everything else that we're there to do, which is education, public safety, infrastructure, investment, criminal justice, everything else out there. It's going to take that money away from that. And so for us to really meet our obligations and our responsibilities in the Medicaid program, we can't just keep doing business the same way we've been doing it. For those that are in the MCOs and stuff, you know good and well what we do. We come in and say, these are things we want you to do to rein in costs, and we have expectations of dollars that can be saved as a consequence of that. But truth be told, you know, there needs to be, I think, a much more fundamental look at how we deliver health care and not sick care. And I know that's a long overused phrase out there. But, you know, let's face it, you know, John Zerwas makes a living out of sick care, not health care. So how do we, as the people who really, with our pen and paper and what we do, drive the health care costs, how do we become people that can actually thrive and you know, really, you know, make a huge impact in the healthcare world out there, but at the same time, pay the bills tomorrow and next week and so forth.
Mm-hmm. And how about that? How do we move a system from sick care to health care in Texas, particularly when I think we have now gotten our waiver renewed, but it is not a waiver focused on innovation, or not focused on transformation, perhaps, I would argue. I would argue it's focused particularly around funding of good programs, but it's not transformational in my judgment. How do we have a transformational conversation where we've just had one of our big levers, you know, sort of get pulled and we've moved past it? Well, how do we move forward?
You know, I don't think any of us have the exact answer. Some thoughts that I have, I would love to increase personal accountability for health. I mean, I go to the doctor if I'm healthy once a year, and I spend 15 minutes with them. And then the rest of the year, I have to take care of myself. So what does that mean? And I know all of us in the room are aware of statistics around obesity and diabetes in Texas and other health concerns. And we've really got to somehow educate and incent individuals to have more ownership. And then I think that we really do need to look at value-based reimbursement or other ways of working with providers and not paying per click so much, but you're keeping them healthy, so let's pay for that. What's the outcome? And how do we do that? And I think that's where everybody's being very flexible and willing to try different things. And I think it's going to take that. I think that the MCOs are excited to try different payment models and to have a lot of different pilots. I don't want to do one thing and say this is the answer, because it may not work everywhere. So.
Kevin, how would you measure the effectiveness of the last round of waiver activity, waiver funding, as we transition into the next round?
I think that, I talked about disruption and what does that look like. I don't mean that in a bad sense. I think disruption means innovation, and that means value-based payment. And I think what we're trying to get to is alignment of clinical and financial models, which are misaligned. I don't think anybody can disagree on that. And the last 1115, well, the first time that we got the 1115 waiver, I think it was the same as this last renewal. We really wanted to try and create the right incentives to align quality and outcomes and do the right things. And by the way, from a behavioral health perspective, there's a lot of money being generated into our state around behavioral health of this $6 billion. I go out and as a behavioral health representative, I know that our MCOs by 2021, again, have to have 25% of their payments to providers in value-based. And I want to help our clients to do that. And so some of those should be behavioral health. And the last time the 1115 was going away, I would go to conferences like this, and I'll say it again. If you have 1115 waiver funding and we can prove outcomes, I'm willing to pay a lot to bring that in and pay for it as an MCO. And if you have a true integration behavioral health PCP and you're willing to accept Medicaid or Marketplace, we do some Marketplace as well, please let's talk. But every time I say that, it's really hard to find those that are actually proving what I think the intent was. So it has become a funding mechanism, funding very good programs that are needed out there in the community and hardworking folks. But I don't know if it is getting us to the point of aligning our clinical outcomes with our financial outcomes that is system-wide.
Mm-hmm. John, being a citizen legislator trying to figure out this stuff is not easy. Even if you are a medical professional, there's this sort of ongoing tension or recent tension between the House and the Senate. There's some tension or at least some turnover in the commission that leads to some additional questions. How would you sort of frame the House and Senate relationships, the legislature and administration relationships, particularly at the commission, vis-a-vis this ambition of being more transformational? In other words, is the legislature ready to drive policy that leads to a more transformational place? If it wanted to, is the commission ready and the rest of state government ready to implement that? How would you characterize the state of state government there?
Right. Well, I think we had a session of the 6 that I've served, and none of them have been exactly alike. But I would certainly highlight this one as being one of the ones that is, I think there was a great tension between the House and the Senate. Now, there's always a bit of that, and that's healthy. It's good to have that. That's why we come up here, is to put that tension on the table and have civilized, discourse over what the different issues are and stuff, and hopefully come out with policy on various issues that serves the state well. We had a lot of things last time. I shouldn't say a lot of things. We had a few things last time that had an overarching reach on a lot of other opportunities to make healthcare policy or to make policy at any level, frankly. And it's no secret to anybody sitting in this room what those issues were that led to that. But I think, if we can put aside some of those things where there's a pretty intense philosophical difference, if it's not going to have a dramatic impact on a certain area, it's going to let us have a greater opportunity to, address some of the things like the healthcare debate that's going on, like the school finance debate that needs to happen, needs to desperately happen. Things that are very important to mental health, women's health, looking at things related to maternal morbidity, making sure that CPS is well funded and that we're taking care of the kids that are at risk in that environment. When we're having to deal with other issues, whether it's on the table or whether it's just they're still in the conversation, it dramatically decreases our ability to be effective. And so I'm hopeful that as we go into the next session, there certainly will be leadership change in the House. Speaker Strauss is not going to be returning. Yours truly would love to be that person that sits in that particular seat, and I look forward to the opportunity to do that. But certainly, the thing that has served me well in my time is that you've got to have, good open communication at all levels. Even at times when it's fairly difficult to have that conversation. That's what people send us here to do, is to have those difficult conversations and hopefully get to a place where we can all agree that this is about the best thing that we can do for the state of Texas. And that's what I would look forward to. I don't think that we were fully effective in that during the last legislative session.
Yeah.
But every session is different, and I think that we'll have the opportunity to take up some of these critical issues.
Recognizing that there are only a handful of votes for that speaker position in the room right now, among the 300 or so. Since you brought it up, do you want to just maybe sketch what you think your vision for the next Texas speaker would be? Like, how would you like to use that position?
Well, I mean, ultimately, the role of the speaker is to just preside over the procedural aspects of the House. Clearly, it has a very, very influential role in addressing certain types of issues that come forward, and as we have seen over every speaker, not just Joe Strauss, but certainly with Tom Craddock when I was a freshman, and every session prior to that, the speaker does have the ability to influence legislation in a way that's above and beyond that of every member in the House. I will say, though, that my perspective on this is that the strength of the speaker is their ability to really make sure the process works, and the strength of the speaker comes in ultimately his or her appointments. And the chairman clearly have a very, very strong and influential role in that regard. And I'd say that's where ultimately the speaker's strength is. There's no doubt that you're going to align people with what you think is in the interest of the state of Texas, but you can't sacrifice the process by which legislation should be heard, that by which every 168,000, 170,000 constituents of a representative in East Texas wants to have their voice heard. The process, as I'd like to say, and as many of you have heard, is very, very good at weeding things out and killing bills. And I have certainly been the victim of that, and a few times I've been successful in overcoming some of those things. But ultimately, I think the process that we have in place in the House, and perhaps similarly in the Senate, is going to really flesh out the policy issues and ultimately serve the state of Texas very well.
And let me ask you a question that I don't believe there's a clear answer to, which is, we talked about this a little bit last night, is the issue of maternal health. And what are your thoughts on why this problem of maternal health is such a difficult nut to crack, and why is it so acutely experienced in Texas? It doesn't feel like anybody has a good sense of why that is so complicated. As an MCO with a lot of data and a lot of system-wide scope in many ways, what are your thoughts on that topic?
Well, as you alluded to last night, we had a lively discussion about that and didn't come away with any concrete answers. I think there's probably a lot of contributing factors, right? And I think that they vary by geographic area. They vary culturally, and they just vary for so many different reasons. It's concerning, right? As a Texan, nobody wants to think that we are at the end of the scale of maternal and fetal health, or that we have some of the lowest quality nursing facilities in the state. I'm a proud Texan. I want to be up at the top. So we need to all work together, and we need to have those dialogues. I know that there's going to be a lot of discussion coming up as part of the interim charges, so I'm excited to hear that. I know that all the MCOs are very committed. Having a healthy baby, as a mom, I will tell you it's a miracle to have a healthy baby, right? There are so many things that can go wrong, and you are so grateful. And then we need to keep the kids healthy, and we need to keep the moms healthy. And I'm very excited that behavioral health is more a part of the discussion. I think postpartum depression has not had quite the voice and spotlight that it deserves. So I think that we'll see more of that, and more ways where the community and providers can perhaps rally around new moms. On the Medicaid world, we have to recognize that our moms are young. A lot of our moms are teenagers, 15 years old, and they don't know how to take care of themselves and their babies. And so that's some of the most rewarding work that we do.
Yeah. Kevin, let me ask you sort of a different question, but building on Ann's connection to behavioral health. Beacon is, I believe, the largest privately held healthcare organization in the country. And so you're in a lot of different states doing a lot of different kinds of work. And while you are not in every state doing a lot of work, I wonder if you could sort of sketch where you put Texas on the behavioral health continuum vis-a-vis states that Beacon works in and has experience with. How are things going here?
So Beacon has 50 million covered lives across the nation, delivering behavioral health-centric services. Here in Texas, we have 1.2 million, about 800,000 of that is CHIP and Medicaid kids. And I think what we're working towards here in Texas, as well as across the rest of the nation, is about integration. And when I say that, it's not just integration at the provider level. That's the ultimate goal. But I think the first step is you got to integrate your funding streams. You can't create disincentives for spending more on behavioral health. And I say this delicately with any of my colleagues that are in the room here, but for those of you who know North Star, I'll use that as an example. North Star was in the Dallas area. It was a Value Options. We acquired Value Options, and I was one of the folks who came in and helped to wind it down. What I learned was that was a spectacular operation in terms of having analytics and really managing the behavioral health of the Dallas area. And being able to reduce the costs. It's value-based purchasing where we can now do equine therapy, where you can do a lot of innovative value adds. But what it didn't do very well was integrate in with the physical health, and that was ultimately, I think, what happened. So we've taken a lot of that leadership, and now we have them integrated in with our health plan clients, sitting side by side. 25 people at a hospital in Dallas. We have 15 at a hospital in Fort Worth. So they're the like employees. So that gets to my second part. We have contracts that are now BH and medical agnostic, so we're not incentivized to spend any less or more. And we've been able to prove that where we're spending more on behavioral health in certain markets, in Texas, you actually see a less amount of physical health spending in those same markets. And so that's the second tier, the operations of the payer and the payment streams. And then I think the third one, that's what we're trying to get to. How do we find truly integrated providers, and how do we get them to that point? Some of the most integrated providers I've seen in Texas, near where you are in Houston, and they keep asking me I did a tour of them, and it's a great facility, and I haven't donated yet, but I will. Instead, I'll plug them. They're called Healthcare for Homeless, and I did a tour there, and they are really integrated in terms of their physical, dental, vision, behavioral health. The facility set up that way. Guess what? They don't take any insurance. None. They don't take Medicaid. They don't take disparate payment. So I asked my question, what are we doing wrong as payers? Are we not finding the right providers to incentivize them well? Are we not working with them in the right way to share data to get to that place. So that's across the country. That's what we're looking at. How do we link the payment streams with truly integrated providers? And that's what we want to get done.
So, John, correct me if I'm wrong, and I often am, and very well may be now. But it seems like there's less of an appetite to engage on real deep or significant health policy in the legislature for a host of reasons. But yet, at the same time, when we include federal funds, Medicaid is now, I believe, the largest portion of the overall state budget. So there's this sort of fiscal imperative that is sort of concurrent or running in parallel to kind of a political diminution of the interest in healthcare. A, is that accurate? And B, does the fiscal imperative sort of force a conversation, maybe around procurement or other ways where the state government writ large can get to significant reforms?
Right. I think, first of all, I think there is a very significant concern regarding the fiscal imperative as to the growth of the Medicaid program. It is consuming an ever-increasing amount. It's outpacing other programs out there, although I think we have seen some improvement with the, transforming into a statewide managed care organization platform. Mm-hmm. I think it's been helpful, and I think a lot of us being legislators, haven't really appreciated the value that has brought. I happened to carry the bill with Senator Nelson that moved Medicaid managed care across the entire state. Some of that to the chagrin of my medical colleagues, but in general for the state of Texas, I think it has been a good thing. I would say that we have saved money. We have delivered cost-effective care. But it has been on the backs of certain individuals and certain groups of individuals as a consequence of that and stuff. So I think what the next leap that has to occur is not just continuing to do the things we've done them, but that and perhaps the procurement things that happen periodically and are coming up are the opportunity for us to do that, to say that we're going to reward, as Kevin said, you're willing to pay pretty good money for people that are willing to demonstrate that they can integrate the care and deliver high quality results and rein in the care ultimately. I always like to share with the audience, and they're probably tired of hearing me because I see lots of people here that I know, but when we actually looked at the Medicaid program as it's a voluntary thing. The state of Texas doesn't have to do that. We can opt out of it. And Governor Perry at that time wanted us to seriously think about that, in fact. And so we had the Health and Human Services Commission look at that under Tom C's, say, what does that look like? What does that look like if we jump out of Medicaid and we develop our own indigent health care program because we have so much money we can do that? Well, they did go back and look at that, and they came back with what was not only a fiscal calamity, is certainly a human calamity. And so you kind of take that off the table, and say, okay, what can you do then to actually try to change this program that's going to, and I say this program, but I refer to it to all insurance programs out there that are going to really, change the way healthcare is delivered. One, I think people do have to have skin in the game. I think you have to be putting money on the table. Perhaps at something maybe at the most destitute levels, but most people can put some money on the table, and it changes their healthcare behaviors. There's a county health plan in San Antonio that did this, in fact, and they very clearly saw people that took on different healthcare behaviors as a consequence of doing that. For what most of us in here would say is an insignificant amount of money to put down at the front desk when you check in, $1, $2, $5. Those people took pride in the fact that they were paying money, hard-earned money, for their healthcare programs, for their healthcare in general out there. The other one is the one that we've talked about already at a large degree is how do people like John Zerwas and all the healthcare systems out there get paid? How do we get paid? How do we turn this around so that we embrace population health and ultimately, we get paid for keeping people out of these high-cost environments, which is where I make a living, frankly, That is not an easy task by any means, but there is some of that activity going on. And I think that it's being driven by some organizations just in terms of looking at this is where we're going in the future. Under Obamacare, I think we saw a little bit more of a push to go that route. But we were seeing this happen before Obamacare even became a reality. And now we're seeing some of it taken apart and so forth. But in general, I think the industry of healthcare, which includes all of us sitting up here and the patient constituency also, are looking towards a better system, a system that helps me lead a healthier, better life at a price that we can all afford. That's only going to happen if we actually start looking at ways that are going to embrace populations and actually start to do the things that are going to generate healthier lives out there at a more cost-effective level. And there's been some really good, dramatic examples of that, not only in Texas, but across the nation.
Yeah.
Can we catalyze that and watch this proliferate? I think we're going to be able to do that because I think a lot of it is driven from within the healthcare sector itself, even outside of what policymakers are talking about.
Yeah. Kevin, how would you characterize, now that we're 6 months after Harvey, how would you characterize the impact of the hurricane on the healthcare system in Texas, particularly sort of through the lens of behavioral health? Are we seeing things now 6 months later that we didn't maybe think about last year? Or what should we be thinking about, or what should we know about from where you sit about that experience now that we're in February of 2018?
I think that's a really tough question because it's so pertinent, and there's going to be a lot of decisions that are made, I think, in the near future by policymakers and others around Hurricane Harvey. I would say from a behavioral health perspective, there really wasn't an impact for the first 2 or 3 months. I'm taking a look at our data in the Houston area to see if now there's increases in outpatient visits, to see if there's increases in inpatient visits. From a risk management point of view, it's hard to foresee the future of behavioral health at a hurricane of this magnitude. I can tell you that, and I'll give you an example on the East Coast too of Beacon. As you get these large events, you will typically see a huge cost savings for any risk-bearing entities because people aren't going to the doctor, they're not going to their behavior vendor. So then you kind of get a backlash that happens. But for something like this hurricane, you're going to see the effects of that within population health for a long time. And not just behavioral health, I'm talking about population health. I don't have a good sense of the ground, of the infrastructure. Sure, I've been to Houston, but there's a lot of other experts in here that can answer that. Yeah. All I can say is that this has a long tail on it, and it's not just behavioral health, it's population health. And we're going to see it in our cost and spending structures.
And same question.
Yeah, that was an amazing event, right? And it was amazing to me. I grew up in Houston, and what the MCOs dealt with was what everybody was dealing with. It didn't just impact patients and members, it was our staff too, right? So there was a catastrophic kind of impact, and it was across the state because then everybody started moving to Dallas and other places. So we actually had a different experience on the financial side. I mean, historically, that does tend to happen. You know, if you can't get to the hospital, then the claims will go down. But what we found is that a lot of our Star Plus members are people who were medically fragile and had chronic conditions. Without the supports that they typically got sicker faster. If they were in the hospital, they didn't have a place to be discharged to because their home was gone. So it was truly amazing. I think we had some great lessons learned. I think all of us are excited. You know, I wish we didn't have to always learn things through the School of Hard Knocks. But certainly getting some mobile dialysis, getting some pharmacy availability, some things that go to the shelters. I think everybody saw that as something that would really help in the future. I know that HHSC has taken this as a very serious topic and is studying it, but I think we all are.
John, same question.
Yeah, I think over the past several weeks, the Appropriations Committee has been having on-site visits in various impacted regions. So we've been down in Corpus Christi, we've been in Houston, we've been in Beaumont. We'll go down to Victoria, and then we'll kind of wrap this all up and see, our job is to determine what's the fiscal impact going to be. We're getting a very clear message from this that it's going to be a significant dollar amount. You can just see the amount of money that we're having to spend out of the 2-year budget and pull it forward, as in order to make ends meet for people that have been impacted by it. A lot of people have criticized the governor to some extent for not calling us back to use the so-called rainy day fund. But you probably have also heard him say we are spending the rainy day fund. He's right, on both counts. We don't really need to, call people in to spend rainy day money right now. But when we come back in January and we have to balance up these budgets from which we're taking a lot of the money right now to pay for things, it's going to be a sizable number. And he has said, and I've even heard the lieutenant governor say, the only place to get that is the rainy day account, the economic stabilization fund. And we're committed to doing that. I don't know exactly what that dollar amount's going to be. My hope and prayer is that we don't face this again coming up into the next hurricane season and see another disaster like this, or see some kind of wildfire disaster, any number of other things that could happen out there. If we see another, big event happen to Texas, that money is going to become pretty significant, as a matter of fact. So we're looking at it from that standpoint, from a fiscal impact point of view. Mm-hmm. We are fortunate that we do have a very, very sizable fund that we can pull from. During the interim, it can only be appropriated by virtue of the legislature coming back together. I don't see that happening. I don't see a need for that to happen, frankly, right now. And I think that ultimately we'll just have to tap into it when we come back in January.
Do you think that, let me ask sort of two questions related to federal funding of this response. Do you think that there's any potential future federal funding that might come in, or has that ship essentially sailed? And did the governor ask for enough support and help from the federal government to help offset these costs, in your view?
I'm very complimentary to the governor on this, and that is I think that we worked well with the Trump administration, in fact, to get a better matching rate for monies for things that would otherwise take a 25% match. We were able to negotiate and get a 10% match, and these are big dollars out there that we're talking about, and so. I think we did well on that. I do think that there will be more money coming down from the federal government. The governor and our senators and representatives up there are keeping this very upfront, in terms of recognizing the need to do some things, not just to recover from it, but as the governor likes to say, rebuild, which means that we need to have some things put in place, especially in the Gulf Coast region, that are going to mitigate some of these disastrous effects. The biggest dollar amount one is obviously the Ike Dike, they like to call it, along the Gulf Coast region. The Port of Houston is an incredible risk of an event that would just absolutely cripple the port and cripple the city of Houston should a hurricane hit directly there and cause a flood event there that would be very difficult to overcome. There is a solution out there, I think. It's a big dollar solution, I think somewhere around $8 billion. But that's one that, certainly I think if you look at what the overall economic impact would be, not just to the state of Texas, but to the nation as a whole, it would be a very wise investment. There's a number of other things identified in a very, very comprehensive document that Chancellor Sharp has put together with a lot of people's help, and the governor has used to actually request, funding for very, very specific items out there. And I think there's more money to be had, and I think that our delegation, both in the House and the Senate, are working hard to make that happen.
Let me ask you sort of a sheer political question, John. We had a panel earlier today that predicted that this year's elections will lead to probably more Democratic legislators and a more conservative legislature overall. Would you, mostly because of primaries and conservatives beating more moderate members in the primaries, would you sort of foresee, do you think that's probably accurate, or how would you differ from that in terms of what 2018's elections might look like for the legislature?
Well, some of the people are going to change, obviously. I can't really speak to whether there'll be more Democrats or not, It is probably one of the livelier primary seasons that I've seen out there. But as we know, the districts are largely written such that a member of a particular party is generally going to get elected in November. So there's not a whole lot of true swing districts out there. There's a few. And if there's a few, then are we looking at having, as many as 60 Democrats in the House and 90 Republicans? Maybe so. Is by more conservative, I would think what you're saying is, are those 90 Republicans, if that's the case, a little bit farther to the right than the temperature that they are right now? I don't think so. I think largely the temperature of the House and the temperature of the Senate stays unchanged, with a few different people sitting in those seats.
Interesting. And as you sort of look ahead, we sort of started with this looking ahead question, but if you could provide sort of the years of your experience into counsel to this group and to folks that will watch this, how would you counsel elected officials, healthcare professionals to try to navigate this next year in terms of the uncertainties in healthcare and health policy? What wisdom would you impart to people trying to make it through healthcare today?
Wow, that's a great question. I want to turn back to you and say communication is tremendous. Communication and relationships. And I talked earlier about partnership. These are big problems, and they're going to take all of us working together. It's very important that voices are heard, and that's where we do get the ideas. I think, I've been doing this a long time, and last year I felt like everything I used to think I knew, I don't know anymore, that the world is in a very different place. And while it is great to have experience and kind of know some things, it's really good to kind of pull back and take a fresh look at things. I think data is going to be very important to all of us. I think information and collaboration are the two things that I would really focus on in the future.
Kevin, what counsel or advice would you give this room of advocates and professionals?
I can't disagree about communication. I think why it's so important is, I said disruption for the next 4 years, and we've been through a lot of disruption, and it's not necessarily a bad thing, but it does cause friction in relationships between organizations within markets. As we continue to plod through where I think we've been going for the past 8 years, and will continue, providers looking more like payers, payers looking more like providers. Talked a lot about the Medicaid disrupt, but I mean, we can't disregard the commercial market as well. I mean, 60% of payers are commercial here in Texas, and we all heard about the news of Amazon, J.P. Morgan, Berkshire Hathaway coming together. And what does that mean? I mean, it was just a few weeks ago where we had CVS Aetna that tanked everybody else's stock, and now their stock gets tanked. So this is all disruption that's happening as I think that we are trying to align financial and clinical models. And the only way that's going to ultimately get aligned is by folks in this room continuing these types of conversations.
Mr. Chairman, Representative, Dr. John, what counsel would you provide to the folks in this audience?
I think the idea that we all have the ability to listen to other people's perspectives on things. And believe me, I have to remind myself of that often. Look, this sounds like a great idea to use Zerwas, but is it a good idea to, everybody else out there? And I think, where we convene people with a similar respect for listening to ideas and thoughts and putting things on the table, then I think that we're going down the right pathway to do that, It doesn't make it easy. None of this work is easy. None of us would be doing what we're doing. If it was something easy, it would already be done. But I do think that it's something that's achievable. The challenge is again, how do you make something that is going to work so well in the next decade, work for me today. You know, how do you make that transition happen? As crystal clear as it may be, you still have to say, how do we strategically get there? And I think some of that is happening, in fact. So to me, it's not all doom and gloom. I think some of the things that I've heard up here today and some of my experiences that I've had out there, I remain optimistic that we're going to get there, but we're not going to get there overnight. But we can take steps forwards and not backwards.
Good. Mr. Chairman, Representative Dr. John Zerwas, the Chair of the House Appropriations Committee, and Rote President and CEO of Molina Healthcare of Texas, and Kevin Denmark, State Director and Vice President at Beacon Health Options for the state of Texas. Let's give them a round of applause.